Thank you, Dr. Rajput. At the outset, I am thankful to Diabetes India Organizing Committee, in particular, friend Dr. Bansi, Dr. Krishna, Dr. Siadikot, having given me this opportunity to be part of this prestigious faculty and address this August gathering of physicians today morning. As Professor Shubhankar in the beginning said, there has been, I'm told, I also came today morning, that there has been a session on SGLT2 inhibitor yesterday also, and with a senior partner already almost covering everything on SGLT2. But I must appreciate, as a senior player, as an opening batsman, I'll address him too as Saurav Ganguly. He has still kept enough space for me, for a new player to come and sort of make a ground on SGLT2 inhibitor. So, in fact, I'll start where Professor Shubhankar left and try to touch upon the data, give little bit comparison between CANA and DAPA and little experience on AMPA, and to make positioning of the drug, clinical potential of SGLT2 inhibitors in early and advanced stages of treatment. You know, last 2 to 3 decades, we have come a long way as far as our understanding about pathophysiology of type 2 diabetes is concerned. Initial days, we knew it was beta cell dysfunction, increased hepatic glucose production from the liver, and resistance into adipose tissue and muscles. Thankfully, 2009, defronzoration taught that probably it is much more than that, and it is an omnious octet which is now addressed to. We are wiser from UKPDS telling that about 50% of beta cells are dead or lost by the time you have diagnosis. So possibly down the line, over 6 to 7 years, most of the patient will either require insulin or addition of new drugs. Unfortunately, in the past, we have been relying primarily after metformin on sulfonylurea, sort of to overwork beta cells so as to maintain HbA1c closer to 7. But it is a very good data telling you that every 3 kg weight gain sort of offsets benefits you which might get even by 1% HbA1c reduction. So it is very rightly said, monotherapy probably almost always progresses to combination therapy. 3 years post-diagnosis of diabetes, approximately 50% patient will require addition of other drug. And down the line, 9 years, almost 75% patient will require multiple therapies to treat to target or to stick to the target of 7 or less than 7. So, not only with that understanding about pathophysiology, fortunately, we have a big armamentarium of drugs. Newer mechanisms which are getting understood and which are getting now addressed to. Topic for today obviously is to address increased glucose reabsorption which happens through kidney, which Dr. Shubhankar said. SGLT2 inhibition, it's a sort of novel treatment strategy for type 2 diabetes with having 3 drugs, AMPA, CANA and DAPA. CANA is already launched in the market and DAPA is almost getting launched maybe this week or next month, and couple of the partners which are in phase 3 also. This slide I'll just address to all the mechanism has been already covered, that it is the increased plasma glucose level which gets too high. Once it exceeds that transport maximum for glucose or TMG, glucose gets reabsorbed into the body. Glucose gets excreted from the body, and this leads to renal glycosuria. Actually, what is being done in SGLT2 inhibitor is we are trying to mimic a mechanism which is there in renal glycosuria. So we are sort of mimicking that variant which is there, which we have studied over the years, that nothing happens even if you have constant renal glycosuria, and that probably could address the safety of the drug, which although Dr. Shubhankar said it is getting launched, so we have to have test of the time. Unfortunately, in diabetes, glucose reabsorption continues in spite of the fact there is already persistent hyperglycemia. This is because of the fact that this TMG is higher as compared to normal glucose tolerant patient. And if you see this slide, if you try to extrapolate or see human exfoliated proximal tubular epithelial cells from the urine and try to isolate them, you could see that there is an overexpression of SGLT2 as well as GLUT2 expression in patients of type 2 as compared to normal glucose tolerant patient. So here if you just block SGLT2 receptor at the proximal convoluted tubule, where they account for almost 90% of the activity, with 10% of activity happening at S3 segment by SGLT1, probably you can create renal glycosuria, and in other way you can correct persistent hyperglycemia which might happen in the setting of type 2 diabetes. I'll of course address both CANA as well as DAPA, but most of the data, because of the scarcity of the time, I may not be able to take all the studies with DAPA and CANA, but in the end I'll try to differentiate. CANA is a molecule which gives you competitive, reversible and selective inhibition of SGLT2. Mechanism of action is independent of insulin. That is what is the beauty of this drug, is that this mechanism is not related to beta cells. So even if you try to address this drug at the end of the spectrum, maybe after 10 years of the onset of diabetes, you probably still have euglycemia if it is already added to sulfonylurea, metformin, maybe DPP4 also. It lowers renal threshold for glucose, that is RTG, and induces urinary glucose excretion to the tune of about 80 to 120 gram glucose. So ultimately you will end up with almost 300 to 400 or 480 kilocalories per day. With that you will have not only osmotic diuresis, but you will also have a sustained type of weight loss which might happen with this drug over 2 years or 3 years time. So this drug reduces RTG and increases urinary glucose excretion. You could see it moves this curve towards the left, so ultimately ends up with renal glycosuria. And if you have the evidence compared to placebo with 100 milligram or with 300 milligram, this RTG significantly comes down to the tune of what, almost 90 to 140 milligram. Otherwise, in diabetes, it has been seen that the threshold might be more than 230 or 240, while in a normal glucose tolerant patient, it should be early at 180, but it is never a sharp cutoff. There is always a little splay which happens towards 180 milligram percent. This is what is the data with canagliflozin, cantata, various studies on monotherapy, dual therapy, triple therapy with combination with insulin. And as Dr. Shubhankar said, now even data with DAPA is available even in the setting of type 1, that once it is added to type 1 patients, those who are already on insulin, it might result in some amount of weight loss and reduction of doses of insulin also. It has been widely studied, 36% patient from North America, almost 30% patient from rest of the world, and 26% patient from European Union. But best thing is that almost 11% patients happen to be from Indian country also. Monotherapy versus placebo, what is labeled as cantata M, then dual therapy, where it has been compared as an add-on to metformin versus placebo, and CETA plus metformin versus glimepiride, then metformin plus sulfonylurea versus placebo, and then canvas, which you already touched upon, which is going to be CV outcome data. It has also been studied in moderate renal impairment and also in elderly patient. So the first study, which is a cantata M, that is efficacy and safety of canagliflozin monotherapy in patient with type 2 diabetes who were inadequately controlled with diet and exercise. Moment 100 or 300 milligram was added as compared to placebo. You could see that there is a significant HbA1c reduction to the tune of almost 0.77 with 100 and almost up to 1 when this was added as 300 milligram. And that is understandable because with monotherapy, these patients are almost like naive patient. Higher is HbA1c, greater is going to be HbA1c reduction. And it not only reduces fasting sugar to the tune of about 25 to 30 milligram or more than 30 milligram, there is a significant postprandial glucose regulation which happens and reduction happens in this patient, which might be to the tune of about 40 to 50 milligram percent. But best thing about this drug is that it helps in reduction of weight, not only because of osmotic diuresis which happens, but also because of the fact that there is a constant energy loss to the tune of about 300 to 400 calories per day. So you will end up towards, this is a 26-week data with weight loss to the tune of about 2.5 kg just with 100 milligram and almost 3.5 kg maybe with 300 milligram just observed over 6 months period. And it is associated with significant reduction in systolic and diastolic pressure because of osmotic diuresis effect, as well as he has already told you ROS inactivation happens. So not only systolic goes down by almost 5 millimeter, diastolic also comes down by almost 2 millimeter. So it is something like having a drug reducing 5 by 2 millimeter when patient is say already having comorbid situations like obesity and hypertension. So it could be sort of an additional drug working through anti-hypertensive mechanism also. So across the lipids, there is a significant reduction of triglyceride. LDL, of course, little bit goes up to the tune of about 7 to 10%, but then HDL also comes up, thankfully, and that addresses the lipid profile in a neutral way so that that balance is maintained. And fortunately, or maybe expected is that long-term cardiovascular benefit should come out of that. So once you use SGLT2, not only beta cell function and markers of all beta cell expression improve, pro-insulin-insulin ratio improves, and C-peptide pro-insulin ratio also improves, and area under curve you could see in all the studies has improved once this drug is used for almost 1 year period. So together, whether it is used as monotherapy or in combination with sulfonylurea or in combination with metformin sulfonylurea or metformin pioglitazone, throughout there has been a significant HbA1c reduction more than 0.7 all across, even with 100 milligram and little higher with 300 milligram %. And there has been a consistent weight loss to the tune of almost 3 or more than 3 kg, both with 100 milligram as well as with 300 milligram. This I already told you, in all therapies, whether it was dual therapy or triple therapy, there was a reduction of blood pressure, systolic by almost 5 and diastolic pressure getting down by at least 2 millimeter. Once it has been compared with as an add-on to metformin versus glimepiride, in this data you could see, which was almost 1 year data, that those patients required almost more than 4 milligram. Mean dose of glimepiride was 5.6 milligram. So once this data was compared versus 100 milligram or 300 milligram Cana, there was an almost equal HbA1c reduction. So you could say that, in other words, it worked like almost glimepiride more than 4 milligram dose as an add-on to metformin. And it provides durable glycemic improvement. I told you, as is the beta cell dysfunction growing, obviously there is going to be a sort of loss of glycemic control, especially with the sulfonylureas. Durability of glycemic control has only been established with TZs or Pio or Rosi or other glitazones. But with Cana, that, or with any SGLT2 inhibitor, that advantage might be there because this mechanism is independent of beta cell function. So you might have a sort of sustained glycemic reduction over 2 years period. And there is going to be a sustained reduction. This is the data again, comparison with glimepiride as compared to glimepiride with Cana and 300 or maybe even 100 milligram. There was a significant fasting reduction. And best thing was that there was a loss of weight, which fortunately is primarily happening through fat mass loss, not lean mass, although to some extent you are going to lose lean mass also or protein mass also once there is a persistent glycosuria and there is going to be an energy loss to the tune of about 400 calories a day. So this significant and sustained weight reduction has been established till 2 years period as compared to glimepiride, and with obviously with glimepiride you expect some amount of weight gain. So net weight loss actually will be much significant with any of the SGLT2 inhibitor once it is compared with any sulfonylurea, and there are not going to be any episodes of hypos or severe hypos, especially when it is compared with glimepiride, where patients, especially elderly patients, are at a very high risk of getting hypoglycemia. Now, once it is compared with as an add-on to metformin versus sitagliptin, this is 100 milligram dose with sitagliptin, and you could see that versus sitagliptin, Cana 100 or 300 milligram was almost equal in terms of HbA1c reduction, which is 0.73 reduction. And again, because sitagliptin is a sort of weight neutral drug, with glimepiride you end up with higher weight gain. Here again there is going to be a comparative weight loss of almost 3.8 to 4 kg. Then even in the moderate renal impairment arm, it has been seen that, as he very rightly said, initially you might have little fall in EGFR, but at the end of 1 year or 2 years it almost levels and there is no further fall in EGFR. And in fact, HbA1c reduction benefits still persist even at moderate renal insufficiency of near 45 or less. Although it is understood higher is the EGFR, obviously more is SGLT2 expression. So HbA1c reduction is better if GFR is more than 45 as compared to if it is less than 45, where it will be to the tune of about 0.4 or 0.45. It is safe even in elderly group, whether it is age less than 65 or more than 65, and you have almost similar HbA1c reduction with 100 or 300 300 milligram percent. And glycemic efficacy of this drug versus baseline. So that is why I said in the beginning, probably this is drug which could be used at any stage of the disease, irrespective of the level of HbA1c, whether it is less than 8, 8 to 9 or more than 9, or duration of the disease. Even if you are addressing with this drug, say after 10 years of onset of diabetes, you probably will have almost equal amount of HbA1c reduction, because fortunately this mechanism is different. It is not based on beta cells, so it's not an insulin mediated mechanism. But definitely there is a word of caution, because there might be little adverse side effect, because it is going to induce glycosuria. So there might be little high episodes of urinary tract infection, maybe little bit genital infection will go up in balanoprostatitis or vulvovaginitis. But I normally say that if you have persistent hyperglycemia, in any case you are going to end up with glycosuria. So all these local candidiasis or infection are in any case going to happen. So if you can actually get down HbA1c down by even with this drug, these episodes are not real concern. And to share with you, I have been one of the PIs in EMPA, not in this drug. There also we had only 1 or 2 episodes of fungal infection. It was a 2-year trial which could be very safely treated with local suppositories, and patient didn't have to discontinue drug at all. But in any case, elderly group, we need to be a little cautious, because the risk of hypertension and orthostatic hypertension or postural giddiness, which might happen especially in the beginning, because glycosuria and osmotic diuresis is more in the beginning, more for say first 6 to 8 weeks or 12 weeks. Subsequently, that urine loss or diuresis settles to almost 200 ml, 250 ml. So if you can educate your patient that you have extra 400 to 500 ml of liquid in the day, probably this aspect can also be handled too. Then good thing is that data from our own country is almost same what you have seen in the overall population. HbA1c reduction to the tune of 0.9 with even with 100 milligram or with 300 milligram percent, and we had almost similar amount of weight loss what happened in overall population. Almost 3 to 4 kg weight loss happened. Again, systolic pressure fall is similar what you have seen in all over, and even diastolic pressure fall is almost same. So here is a drug which can change CV risk factors by not only decreasing systolic pressure and diastolic pressure, it improves glycemic control, it decreases body weight, it changes fasting lipids. Good thing is that it improves HDL, although there might be little bit increase in LDL, but that ratio almost remains. So CV outcomes definitely will be very, very exciting. Of course, these we will listen in this Canvas study maybe by 2017. DAPA, again, it's a comprehensive phase 3 clinical development program with almost 40% patients from Europe and all across the globe. It was used as monotherapy in about 850 patients, as a combination almost in 2000 patients versus comparator also, and special studies with DEXA have been done, and it has also been used in moderate renal impairment arm also. And similarly, as with Cana, I have shown you the data. I'll not be going into the details of these studies because of paucity of the time, but almost a similar HbA1c reduction which happened over 24 weeks, whether it was used as a monotherapy in combination with metformin, in combination with DPP-4, with sulfonylurea TZs, or even with insulin. By and large, you could see that HbA1c reduction was to the tune of about 0.8% all across the spectrum, whether it was monotherapy or as an add-on to one of these drugs. So that probably makes the right positioning of the drug, that there is going to be a persistent weight loss, improvement in blood pressure, little improvement in lipids, and a significant amount of HbA1c reduction, which is going to happen with any of these SGLT2 inhibitors all across, whether you are adding this drug in the beginning, maybe as a monotherapy, or as immediately after metformin, or maybe towards the end when patient is already having diabetes for about 10 years, because this mechanism is absolutely not addressed to beta cell. Even in the moderate renal impairment arm, it has been seen with DAPA, there was almost 0.44 reduction, which was also seen with with Cana also. I have told you, lower is the EGFR, lesser is SGLT2 expression. So obviously, you may not have that good HbA1c reduction, which will happen within normal GFR. Then I just wanted to share this data, which is just published, a pharmacodynamic differences between Cana and DAPA, 10 milligram versus 300 milligram for urinary glucose excretion, renal threshold for glucose, and postprandial glucose excursion in healthy participants. These are not, one thing is minded, not in diabetic patient, these are in healthy participant, and these are the studies which are DAPA 10 milligram versus 300 milligram percent. Endpoints were primary endpoint differences between the two drugs in terms of 24-hour mean reduction of RTG so as to create urinary glycosuria. And in this study, it was a Janssen sponsored study. Hypothesis was whether Cana 300 will provide superior reduction of RTG over 24 hours, and secondary endpoint whether it will mean in terms of some postprandial extra reduction also. As Professor Shubhankar said, Cana has advantage or disadvantage that it a little bit impairs SGLT1 also. So it might get you little better RTG reduction, but then some sort of side effects are to be seen, whether addressing through intestinal mechanism it will lead to some diarrhea or no, although all across in the studies by and large it is found to be absolutely safe. It was a crossover study, 5 days using either DAPA or Cana, then a washout period of 2 weeks, and again then switching on to the other drug. And in this it was found that with 300 milligram Cana versus DAPA, there was a little increase in reduction of RTG versus 10 milligram DAPA, and it was sustained over 24 hours. So in other words, this is, I told you, this is not data from type 2 diabetic patient. It's a comparison on healthy volunteers, that it might ultimately convert into little better postprandial reduction with 300 milligram Cana versus 10 milligram of DAPA. So from this study, they said that although it's a class effect, all SGLT2 inhibitors are going to be same, but maybe with its pharmacodynamics little getting different, and while addressing through SGLT1 mechanism, you might have little lowering of RTG better with Cana as compared to DAPA. Then issues about malignancies, what he has already touched upon, that that bladder, prostate and breast, but I think it has been now adequately addressed. DAPA is already launched and it has already got US FDA approval, because it was found that whatsoever episodes of bladder or breast or prostate malignancies which happened with that drug, they happen probably within 6 months of the usage. So any drug which you are using and within 6 months if you find little increase in malignancy, that probably cannot be related to the drug. That is one. And second thing is that fortunately whether in bladder or in breast you don't have any SGLT2 receptor at all. So probably this drug should be safe over the year. So today you have a drug, a mechanism which is absolutely insulin independent mechanism. Till now we have been addressing mechanisms which are all insulin mediated or beta cell mediated mechanism. Here is a drug which will work through a different mechanism. So it probably will be a right platform that not only you have a sustained glucose lowering, reduction of HbA1c, you will improve on glucotoxicity and lipotoxicity. You will have an additional advantage of osmotic diuresis with initial weight loss and decrease in blood pressure. You have mechanism which is different than the beta cell mechanism or insulin mediated mechanism. So in other words, you are trying to address pathophysiology of type 2 diabetes from adjoint mechanisms. So efficacy probably at all stages of the disease, and there is a possibility of combination with all other anti-hyperglycemic drugs, whether it is DPP4, metformin, sulfonylurea, or maybe even insulin. And there is going to be a extra loss of calories, so you might have a sustained weight loss. So SGLT2 inhibitor probably will meet what was till today an unmet need in the diabetes care by correcting a novel pathophysiological defect, by reversal of glucotoxicity, by reducing HbA1c, promoting weight loss, and by complementing action of other anti-diabetic drugs. That is probably going to be the beauty, and it could be added at any stage of the disease, maybe as a monotherapy, as a dual therapy, or maybe towards the end spectrum of the disease, because it will ultimately get you glycemic control, and maybe because it is addressing various CV risk factors, so maybe outcome from Canvas and other DAPA studies which are going on probably might actually answer that. So here is an SGLT2 which could be used as monotherapy, as an add-on to metformin, sulfonylurea or pioglitazone, as an add-on to oral combination therapy, maybe in combination as double, triple combo therapy, or as an add-on to type 2 also. Also in type 1, although this is still not approved indication, but there is a very encouraging data that it will reduce not only weight but also insulin requirement in type 1 diabetes, and it could be used all spectrum of the disease, maybe an HbA1c of 8, 8.5, or maybe even more than 9. So the right positioning of the drug, ADASD guidelines 2015, that it probably is another mechanism in the setting of type 2 diabetes. So here is a big armamentarium to choose after metformin, other than say sulfonylurea. It could be positioned as a monotherapy, dual therapy, or as a combination therapy with other drugs. Thank you very much for your patience listening.